All right, hello everyone. So, when talking about kidney function, it's important to understand how effectively our kidneys are filtering on the blood. And one way you can do that is by looking at something known as renal clearance, right? And so, renal clearance is a measure of how well our kidneys are clearing the blood of some molecule, of some substance, right? Um, so this is usually expressed in the amount that is cleared per unit of time, per amount of time, so in milliliters per minute, something like that. And so what you can do is you can take a substance or some molecule, it's in the blood, and you run this blood through the glomerulus, it gets filtered, and then you see how much of that substance then appears in the urine, right? And so for it to be completely accurate and the most reliable, there have to be a couple of things that have to be true. And we're down here in this yellow box down here. So what you have to have happen is the kidneys have to filter this molecule, but the molecule can't be reabsorbed, nor can it be secreted from the blood into the tubule, right? So it's all filtered at the level of the glomerulus, and then that's it. It stays there. There's not any additional amounts that are being secreted in, and there's not any amount of that substance or molecule that is then being absorbed out, right? Now, what we'll see is in an ideal world, this is exactly the assumptions that we can make, and this is exactly what would happen. In reality, and in a practical clinical setting, there is the test that's typically used. Some of it is secreted. Some of this molecule is secreted from the blood into the filtrate, so it's slightly, the true GFR is slightly different than this renal clearance that we'll talk about, but it's close, all right? So what you do is you use this formula, all right? So the formula is C equals U times V divided by P. So the C is meaning the clearance, right? That's what we're looking at. We're trying to determine the renal clearance. So how much of a molecule are we clearing, are we excreting in the urine per minute, right? Per amount of time. So to calculate the C, to calculate this clearance rate, you take the concentration of a substance, right? So something in milligrams per deciliter or something like that. You multiply that times the amount of urine that's being formed per amount of time, and you divide that by the amount of that same substance that's in the blood plasma, right? So you have to have these different values, and then you put these values together and you get some clearance rate, right? So when doing this and when calculating this, there's two different molecules or substances that you can be used that can be used. One is called inulin, and one is called creatinine, right? So inulin, in an ideal world, inulin would always be used because inulin is only filtered, so it goes from the blood, it goes into the tubular fluid. There's nothing that is reabsorbed, so inulin is not reabsorbed, and it is not secreted at all either, right? And so it's freely filtered. Nothing is absorbed, nothing is secreted, right? So the amount that is filtered at the level of the kidney, that's the amount that appears in the urine, right? Inulin is a starch. It's a polysaccharide from plants, right? And so the reason I say in an ideal world this would be used is because this is from plants, and we're not plants. Humans aren't plants. We don't have this inulin. So if you use this inulin, you have to inject it into the patient 24 hours before you do the test, right? So it's inconvenient. It's more expensive. You have to go through the process of actually sticking the patient and injecting them with this insulin. So it's not ideal, right? So what's more often used and more simply used here is this thing called creatinine, right? So creatinine is a byproduct of creatine metabolism, and creatine was the molecule in muscles that was helping to transfer phosphates to ADP to make ATP. So creatine is a byproduct of creatine metabolism. Creatine is filtered in the kidney. However, it's also slightly secreted, right? So there is some secretion of creatinine from the blood into the tubular fluid instead of it all being filtered, right? So what this means is that the amount of clearance that you see for creatinine is slightly more than the filtration rate because there's some amount that's filtered and then you add some via secretion, right? So it's actually slightly higher, but it gives you a good idea of what the GFR is, what the filtration rate is for the kidney, right? And so all of this to say you can use this GFR, you use these tests to determine how efficiently and how effectively a patient's kidneys are functioning. You can look at the GFR. If they have kidney disease, you can use this to kind of begin to estimate and begin to look at the degree of kidney disease. So based on their GFR, they're going to be in some other, some different stage of chronic kidney disease. You can also look at it to determine how well certain medications are being excreted, if that medication maybe is being excreted in the urine, something like that, right? So it's a good measure of essentially how well the kidneys are functioning, all right? So if we come back to our renal tubules here, so we've talked about filtration, we've talked about reabsorption and whatnot. When talking about reabsorption and secretion in our kidney, there's one extremely important process that takes place, and this is known as countercurrent multiplication. All right. So this is a process by which you are taking fluid in the renal tubules and you're reabsorbing some things, and at the same time you're also excreting something. You're secreting some things, and again, if it's secreted, it will be excreted. All right. So where this is happening along our nephron loop. Right. This is happening along the loop of Henle. All right. So we're looking right here. So here's our descending limb of the loop of Henle. Here's where it turns. And then here's our ascending limb right here. Here's distal tubule. Here's collecting duct. Right. So we're going to be focusing kind of in this region here. All right. So to look at this word, or this term, countercurrent multiplication. Countercurrent refers to the flow of the filtrate moving in opposite directions. Right. So you have filtrate moving down here. You have it moving down in the descending limb. You then have it moving up toward the cortex in the ascending limb. All right, so that's the countercurrent, relatively straightforward. Multiplication refers to the fact that as the fluid moves in the filtrate, as well as the interstitium, so all of this white space out here, that's just the interstitial fluid, or in the interstitial space outside of the nephron, right? As you move down in the tubule and as you move down in the medullary interstitium here, you're increasing the concentration of different solutes, or you're decreasing it, right? So as you move in one direction, the change is getting larger, right? So you can see this here as you start up near the cortex and the kind of superficial part of the medulla, there's a very low concentration. As you move down, the concentration increases in terms of the osmolarity. So how much solute is in the tubule or in the medulla, right? So what's happening here is along different parts of the nephron loop, it is permeable to different things, right? So essentially in this descending limb here, it is permeable to water, but not solutes, right? So no solutes can leave in this descending limb, only water, right? In this ascending limb here, you are permeable to solutes, but not water, right? So it's essentially the exact opposite of this descending limb. So again, the descending limb, you're permeable to water, so blue is water. Water can leave, solutes cannot. In this ascending limb, solutes can leave, but water cannot, right? So what you can think of this as doing is it's creating a gradient in the medulla, right? So it's making the medulla very salty the further you go down, right? So the further you get away from the cortex, the deeper in the medulla, you're getting a higher concentration here, right? So if we come to this ascending limb first, I think it'll make more sense if we start here and then come over to the descending limb. So as you move up in the descending limb, as you move up in the ascending limb, you have solutes move out of the ascending limb, right? So initially, as you start coming up, you have lots of solutes move out, right? You have lots of solutes move out. As you move up a little bit more, you have some more solutes, and by the time you get up, you have a few more solutes that are moving out, right? So the concentration down here is going to be higher because you had a lot of solutes here. Solutes move out, sodium, chloride, potassium, things like that. And then as you move up, there are still some solutes, but there's a little bit less, right? So they're moving out here. So there's less up here. So you see that here, there's a 1200 milliosmol concentration here. So this just means it's very concentrated. And then as you move up, it slightly goes down, right? Or you could approach it the opposite way. As you move down, it goes up, right? Now, if you think about it, as these solutes move out into the interstitium, they're making this more salty, right? There's more solutes out here. Well, if you move these solutes out, you've then created an osmotic gradient to pull water out, right? Well, where did we say water was permeable? Water was permeable only in the descending limb, right? So if you had some solutes out here, you'd pull out some water, right? If you have more, and remember, so refer to these concentrations over here. So here it's 400 milliosmoles, right? So you have some water that's being pulled out due to this osmotic gradient. As you move deeper in the medulla, now we're at 600. So we have a little bit more water move out, right? You then have it go to 900. You have even more water, and then you have 1200 at the very bottom. You have even more water, right? Well, as this water is moving out, you can think about what that's doing to the concentration of the tubular fluid in this descending limb, right? It's making the concentration much higher, right? Because you're losing water, but you're not losing solutes. So the concentration goes up, right? So then as you turn here, you have a very high concentration of solutes, and then the same thing happens again. This ascending limb is permeable to solutes. So you have a very high concentration of solutes. Solutes go out here, they go out here, they go out here. That pulls water from here down, which creates this very high concentrated tubular fluid, and this process continues and continues and continues, right? So that's this idea of this multiplication. This process continues to occur, and it gets more exaggerated, right? The concentration goes up the lower you get in the medulla, right? So this is referred to as countercurrent multiplication. So you can look at this graph here, and this is showing the same thing, right? So you have water coming out, or if we start on this side over here, let's start with the ascending limb because it's easier to understand, right? So you have more fluid coming out, right? So you have saltier fluid in this ascending limb. Salt is then going into this extracellular fluid, right, or this interstitium. As you move up then, the concentration goes down because you're losing solutes and not water in the ascending limb. And then you can start over here on the descending limb. Because you've pumped out all these solutes, you're then going to have an osmotic gradient that is going to draw water out, right? So leaves via osmosis, water is coming out, and then as water comes out and as you move down in the renal tubule in this descending limb, the concentration of the fluid goes up, right? So as more water leaves the descending limb, the saltier the fluid is that remains in the tubule, right? So the tubule is more concentrated, and then as you move up, very concentrated, solutes move out, that draws water out from the descending limb, and this process continues and continues and continues, right? Now, you also have another thing here called the vasa recta. So if we go back for a second, you have this vasa recta here. This vasa recta helps to maintain this gradient, right? So as the blood goes down in this vasa recta, or this limb here, it passes by the ascending limb of the loop of Henle, right? In this case, it's reabsorbing some solutes and not water, and then as you move up here, it's reabsorbing some water and not solutes. So it's helping to maintain this gradient as you move down in the medulla. It's not creating the gradient, but it's just helping to maintain it, right? So that's the function of this vasa recta that would be surrounding these renal tubules, that would be surrounding these tubules way down here, all right? So we'll stop here, and we'll pick up with the next part, talking about urine. We'll talk about our ureters. We'll talk about our bladder as well.